And now with our next session, Bioethics and Healthcare Part 1. نجدد الدعوة لأساتذتنا as chairpersons دكتور سهام ودكتور ماجدة ودكتور ياسر بعد إذن حضراتكم. With our dearest Professor Ahmed Mandil, Professor of Epidemiology, High Institute of Public Health, Alexandria University. The name of the talk, Bioethics under Emergency and Humanitarian Settings. تفضل.
Bismillah ar-Rahman ar-Rahim. I'd like to start by thanking Ain Shams University College of Medicine, and special thanks are for the UNESCO Bioethics Chair, especially Professor Sonia Azab for bringing us all together this morning. And I thank you also for being the MC, Dr. Hanan. Ladies and gentlemen, my talk today is about bioethics during emergencies and humanitarian settings. And maybe the first question we ask ourselves, what do we mean by an emergency or an unusual situation? Ladies and gentlemen, emergencies could be natural or man-made, as you all know. So natural emergencies could be floods, earthquakes, volcanoes, sandstorms, windstorms, epidemics, pandemics. These are all considered natural disasters, emergencies, or crises. And if we classify them, emergency is less than a crisis, less than a disaster. الحالة الطارئة أقل من الأزمة أقل من الكارثة. And then the second type of emergencies are considered to be man-made. These include aviation disasters, nuclear disasters, biological wars, industrial emergencies, fires, even road traffic accidents. These more or less are considered to be man-made. So this is what I meant by emergencies. Now, during this quick presentation, we'll talk a little bit about emergency populations, research during emergencies, ethical considerations, and here we will shed the light on ethical review processes during emergencies, benefits versus risks, integrity and conflict of interest, and then finally, what did WHO actually do in order to support ethics during emergencies, especially research? So populations during emergencies could be urban, could be rural, could be remote, but the population we really care about most are the populations of refugees, migrants, and internally displaced persons. And we have seen what is happening now in Gaza, in Syria, in the Sudan, in Libya, in Yemen, how these are major problems. The main difference, ladies and gentlemen, between IDPs and the others is that IDPs are moving around within the country itself. Refugees or migrants have crossed the borders to other countries, whether by force or because they are going for a better life. So these are the differences between the three categories of refugees, migrants, and IDPs. The other major population during emergencies are actually the providers of healthcare. And on top of them, we always acknowledge the work of what we call the EMTs, or the emergency medical technicians, who work in ambulances, who take people from the time and the place of emergencies to where they're going to get the utmost health and medical care. And obviously, physicians, nurses, surgeons, MLTs, as well as health educators and pharmacists. All of these are considered populations during emergencies. So why do we need research during emergencies? Well, this is important for the three phases of emergency response, whether we're talking about preparedness for, response to, or recovery from emergencies. And in preparedness, we mean being ready for an emergency, قبل الهنا بسنة kind of thing. And then in response, after the emergency happens, we should understand the epidemiologic features, the access to innovative solutions, and actually try to save the injured, provide health care, take people to shelters, provide them with, safe, secure places where there is water, food, and shelter. And then recovery, which is after the disaster or the emergency, in the rebuilding, إعادة الإعمار. But the research during emergencies should be timely, should be responsive, and should be rigorous. So these are the three, hallmarks of research during emergencies. One way of classifying research during emergencies is that we talk about clinical research, health service research, population-based research, policy research, or even basic science research. So population-based research is on individuals, but in a wider context, where we try to do epidemiologic studies to understand how do emergencies happen, what are the risk factors, and how can we adequately respond to them. But there is also the policy or advocacy research. Can social media be used to improve disaster preparedness? There is also basic science research, clinical research, and health systems research. So these are all types of research which could be held during emergencies. The Council of International Organizations of Medical Sciences, better known as CIOMS, because we actually use acronyms and sometimes even forget what they actually stand for. So about 10 years ago, they actually mentioned in their guideline number 20 that conducting research during epidemics or emergencies is to acknowledge and include the need to generate knowledge quickly, to maintain public trust, and to overcome practical obstacles or challenges. But these challenges need to be carefully balanced with two things: the need to ensure the scientific validity of research and to uphold the ethical principles in conduct of research during emergencies involving human subjects. We also remind ourselves of the Arab Charter of Ethics during Science and Technology, which was put together by UNESCO in the collaboration with bioethicists across the Arab world, which actually emphasized the freedom, the respect to human dignity, integrity and safety, beneficence and non-malfeasance, animal welfare and preservation of environment, openness, but also justice and protection of rights of participants. So what are the considerations for conduct of research in public health emergencies? Now we can ask ourselves four different questions. The first one is, what scientific standards, if any, are we willing to compromise in order to respond quickly to a public health emergency? And who will bear the greatest risks associated with use of unapproved management schemes? There has been lots of talk about what happened during the pandemic, the use of vaccines, the use of drugs. Are we sure that they are effective or not? And you are an infectious disease person, Dr. Friel, you know better than all of us what has been happening over 3 years. Which project has the greatest potential for positive results for people at risk in a public health emergency, including epidemics and pandemics? And how do we decide who will receive first access to a newly developed innovative management scheme? And of course, during the pandemic, we said elderly people, pregnant women, people who are with comorbidities such as diabetes, hypertension, and so on, should receive the vaccines as soon as possible. But what are the areas of bioethical concern during emergencies? Political and cultural issues, pressure on clinical standards, consent, respect, and dignity, prioritization and working with scarce resources, witnessing abuse of fundamental rights and interests, data privacy and confidentiality, security and mass casualty, and tensions between the professional ethics and institutional demands. So the standards which should be met during research or during emergencies are the scientific validity, social value, collaborative partnerships, reasonable risk-benefit ratios, independent review, and moral aspects for participants and affected communities. But this is not without challenges. The challenges of research and observing ethics during emergencies include protection of vulnerable populations. the extremes of age, the women, especially pregnant women, the people who are prisoners, the people with comorbidities, the people who are underprivileged, the mental health people, people with non-communicable diseases. We should protect them more than other populations. The informed consent processes, risk-benefit assessment, confidentiality, capacity building, and oversight. So difficulties of ethics during emergencies include, are we going to really obtain a written informed consent, which is what we prefer? We think that this is very difficult during emergencies. How about the mortality of patients, which is usually high without clinical interventions? How can we do random selection of people, which is quite difficult during emergencies? And then time. The time of recruitment information asking for consent may be late for provision of the necessary management to the affected populations, the morbid and the mortal. Very quickly, we'll look at ethical review, benefits versus risks, and integrity during emergencies. Specific categories of research may be subject to expedited review, and the level would be according to the vulnerability of research participants. So we talk about different levels of review. The review which is generic, the review which is expedited, the pre-approved protocols, and the review waiving. And we ask ourselves, can we actually waive ethical review? And these are all concerns, because these concerns could lead to neglect of issues of exploitation, then can create exacerbate vulnerabilities. They may actually increase therapeutic misconception and lack of clarity of the process itself. So in general, we should actually keep in mind the perception of risk for harm, which may differ in a public health emergency. Individuals may accept higher levels of risk than they would have accepted under non-emergency situations. Also, the changed perception of risk, such as vaccination policies during emergencies. So how can we actually weigh benefits versus harms when we are trying to protect and uphold ethics during emergency situations? Of course, the benefits are clear: the rapid access and the better understanding of the condition. So access to new drugs, scientific evaluation, and so on. And also we better understand the risk factors, the outcomes, and the management schemes if we do research and observe ethics very quickly. But the harms could be adverse effects, inefficiency, violation of rights, and sometimes unnecessary exposure to risks. So how can we adapt to standard ethical oversight, having said all of that? Now, there are 3 or 4 mechanisms which are proposed in order to protect ethics of emergency situations. First of all, we prefer to have a centralized emergency ethics committees. We should prefer the pre-approval of research protocols ready to be used during emergencies, rolling ethics approval, and finally, joint approval by different ethics and regulatory bodies instead of having so many committees ethically clearing research. Now, the question which I asked a few minutes ago, could consent be waived in public health emergencies? This could be only granted for research interventions under very specific conditions when there is minimal risk. This includes retrospective data collection, observational research projects, and when participants are inaccessible or unable to consent. But for all of this, research ethics instruments were known to not being enough to specifically address emergency situations. Okay, are there issues related to data? I think the prior speakers spoke a lot about the data privacy, the data confidentiality, and security. But the issues include the following. Which data are we collecting? And we should not actually collect data khalas. We should take data for action. Recording, transporting, protection, storing, privacy, and confidentiality are all issues related to data. In essence, ladies and gentlemen, we should avoid collecting unnecessary data. We should protect human subjects, and at the same time, do our best to apply ethical principles during emergency situations to protect human subjects to the best of our ability. Thank you very much.
شكرا دكتور أحمد. أي أسئلة؟ تفضل.
Thank you. Can we give the microphone to Dr. Ferial, please? عشان العتب على السمع يعني الحمد لله.
Just the question, two parts. Number one is in mankind emergencies and disasters. There are many information that needs to be disseminated in a proper way, in a research way. But there are many obstacles, even taking consent or even going through a proper ethical approval. So what are the kind of, in these situations, what is the basic minimum things that needs to be maintained? That's question number one. Number two is during pandemic, we have seen publications. So now we finished the research. When it comes to publication, there were many things that happened at that time. Number one, studies or research of not high quality got into big journals. Number two, retrieving of publications because of falsification of data. So what's our role as a bioethicist in this issue? Thank you.
Thank you so much, Dr. Ferial Khamis from Oman. So basically, your questions are really difficult, but I'll try to address them to the best of my ability. Your first question was about how can we address human subjects during man-made disasters and protect the ethics of research and dealing with human subjects. I think the basic minimum is to try to inform the people that they are part of research, that this is going to be for their benefit, and also give them the right to say, no, I do not want to be included. But at the same time, tell them that if this research comes up with better solutions, better management schemes, you're going to be informed and you are going to be the first person to receive this new management scheme. For your second question about publications, absolutely. There has been an epidemic of publications during the 3 years of the pandemic, some of which were actually retracted, as you mentioned, from high impact journals with high impact factors. And I think the burden of proof in this case actually lies with the editorial boards of these journals in the first place. The reviewers who looked at this data, some of which really looked fictitious, but it was still got published because people had, this publish or perish kind of thing in order to be promoted or to be more famous, etc. So I think as a scientific community, we have the responsibility of making sure that whatever we give the scientific journals is actually scientific and real, but also the editorial boards of peer-reviewed scientific journals also carry a great burden of responsibility. Thanks very much for your question. I hope I answered them. Yes, please, Professor Abdul Qawi.
Don't you consider that the patients or population of emergencies are all vulnerable and there are several levels of vulnerability?
Pretty much, yes, sir. So Dr. Abdul Qawi is mentioning that why do we divide people under emergencies into vulnerable and non-vulnerable? I mean, sometimes this is not easy. We definitely prefer to take more care for vulnerable populations at extremes of age, pregnant women, people with, comorbidities. But at the same time, as you have eloquently mentioned, sir, that people under emergencies are more or less all vulnerable. So I think we should actually try to observe ethical principles, dealing with them and doing research on them regardless. So I agree with you and I thank you for your question. Thank you, Chairpersons.
With an online session with Dr. Bilal Azakir, Associate Professor of Faculty of Medicine, Beirut Arab University, under the name of Infodemic During Health Crisis Virtual. حضرتك معانا يا فندم دكتور بلال؟
نعم.
يا فندم أهلا وسهلا، اتفضل حضرتك.
Okay. Good morning, everyone. First, I would like to thank the UNESCO Chair and Dr. Sonia for this invitation. I'll talk today about the infodemic during healthcare crisis. So let me start my presentation by this say of the Director General of WHO. We are not just fighting an epidemic, we are fighting an infodemic. Fake news spreads faster and more easily than virus and is just as dangerous. To start with, what is an infodemic? Infodemic is defined as an overabundance of information, accurate or not, in the digital and physical space accompanying an acute health event such as an outbreak or epidemic. Misinformation, disinformation, and fake news can cause real harm to health, even more harm than the pandemic itself, to the public trust, social cohesion, and emergency response. I think we are all facing this issue of this patient coming to your clinic and have already read about his symptoms and his even sometime reach his diagnosis and trying to lecture the physician about what can be the possibilities and of his diagnosis and even the treatment plan. In fact, some of them are only seeking a prescription for the drug because if they could get this drug without prescription, they would go directly to the pharmacy and get it. This patient is gathering his information mainly from social media, from internet, from Wikipedia, social media platforms such as TikTok, Twitter, or Instagram, where people unspecialized are writing, giving information based on either this information or their own personal opinion. We all remember during the latest pandemic, COVID-19, we all heard about the methanol poisoning that happened in Iran and the different people and articles who talk about herbal remedies for COVID-19. And of course, we heard about someone who said, if you drink bleach, that can cure you from COVID-19. In fact, approximately 800 people have died, more than 5,800 have been hospitalized, and 60 have developed complete blindness after drinking methanol as a cure for coronavirus. And this is not only related to coronavirus. If we go back a bit in the history, we can see that happened also during the H1N1 influenza pandemic, where people, they said, well, it's either a catastrophic pandemic or even a fake flu hyped by pharmaceutical companies. During the Ebola outbreak, rumors has spread that it's a hoax or a government conspiracy that led to physical attacks on healthcare workers, or sometimes believes that bathing in salt water or consuming bitter cola could prevent infection. During the Zika virus outbreak, there were claims that vaccines can cause microcephaly and not the Zika virus itself, and the mistrust fueled by pure communication about the linking of Zika and birth defect. So why we're talking about infodemic? Because infodemic has so many impact on so many levels, on the healthcare level, on the social level, on the psychological level, and economic level. Today, I would like to focus only on two levels, the healthcare and the economic level. So on the healthcare, infodemic can lead to facility overload, where people can go to the emergency for unnecessary visits, leading to overpopulation in the ER, and some really cases that really needs emergency are missed. Resource misallocation, and that happened with the PPE and specifically the remdesivir misuse in India. People that need really remdesivir did not find the treatment anymore. Guideline non-compliance, especially with the wearing mask and vaccines, because a lot of rumors and misinformation about how masks can reduce oxygen in blood, and how can vaccine cause sterility. Care delays because of the lockdown, some patients, mainly cancer patient, could not reach sometime their treatment session, unfortunately. And we know all that physicians and all the healthcare team spend hours, days in hospitals that led to burnout and violence by patient, by families of patient, sometimes the verbal, physical abuse of staff during this crisis that lead to resignation of these healthcare workers. The economical impact is also very abundant. Misinformation about the vaccine led to long-term costs for preventable disease. So because if I can get the vaccine, stop the disease right now, if I don't do it later on, it will cost me more. Rumors, fears about transmission that led to a lot of small business and even medium business has closed, loss of tourism, trades and between countries, panic buying or what we call false treatment, as I said before, with the resource misallocation and supply chain distortion, and of course the distrust in healthcare worker that led to a delay in the outbreak control. This is all caused by the infodemic. So what are the ethical background of infodemic, the ethical issues that infodemic can affect? First principle is the non-malfeasance, do no harm. What about toxic remedies that were spread among population and people start to take them and cause more harm than the COVID-19 itself? What about vaccine denial? Because about all the rumors that we heard about the vaccines, how fast they are developed and everything. The beneficence delayed in public education. We could not educate adequately the public about the pandemic. The autonomy, more specifically, the misinformed choices for the patients, and sometimes the consent undermined, specifically in case of treatment or in vaccination. Justice and equity was also affected because of inequities in information access among populations. So now I would like to focus on the case of COVID-19, and find the source of this infodemic. We all see that that during the year 2000 and 2021, we saw an increase among the number of publications on COVID-19 to reach approximately 150,000 publication ranging from articles, book chapters, and different type of publication. This is understandable because a lot of people would like to work on this to discover scientifically what is COVID-19. Others took ride the wave of the publications that would like to, for personal reason, to get promotion or any other personal reason. More than $10 billion were spent on funding on research working on COVID-19. However, the most dangerous part that caused this infodemic were mainly, not only, but mainly two: preprints and the fast track that led to a lot later on of paper retractions. So preprints are archives, free online archives. Everyone can get access. You can read articles on them. In fact, I think you know about them. When you want to submit your paper to a journal, you can accept to publish it as a preprint in one of these archives. And these archives do not have any peer reviewing. So everything there is not judged already or reviewed by anyone else. So it can be any type of study, anyone can write it down, nobody checked it out. This information is unchecked and unjustified, unverified. So what was the impact? If you observe, if you look into these preprint, you can see that more than 2/3 of all preprint posted on medRxiv, which was launched in 2019, were about COVID-19. We see more publication about COVID-19 than on other papers. This had led to what we call sea of literature, a rise in the level of COVID-19 articles unverified, and some of them untrue. So journals had no options but to decrease the time required to evaluate and publish a manuscript. In one hand, it's good because we know that sometimes it takes ages to get an article published. However, this rush in publication has two consequences. First, that maybe the peer reviewing process is not 100% adequate anymore. Second, it will be over the publication of other topics, and maybe it was very important to get published. So the problem that all this increase in publication, either in preprint or in the fast track of journal used, had led to spread of a lot of unqualified COVID-19 publication, the spread of misinformation, and the lack of scientific integrity. And this led to retractions. If we look at the data, until the day we have more than 300 articles retracted. These articles are published in high impacted journals, Q1 journals. Some of them are very, very famous journals in medicine. So it's not related to low index journal. No, they are among the highest index journals. The cause of retractions were mainly fabrications, falsifications, plagiarism, and dispute among collaborators. So what is the killing side of preprint and retracted articles? That they are potential misinformation source that people can go read. And of course, because it's written in a very scientific way, people will spread this information on social media, on WhatsApp, on all this with a print screen of the article, and they don't know that these articles were already not reviewed or they are already retracted. So they publish results based on flawed research. Why we should discuss also retraction? Because as I am a scientist, I will base my work on others. What if the other were retracted and I didn't notice, or it was retracted after I started my project? So what about the reliability of the published, the trust in the published literature? What is the public attitude? Why we do care about the public attitude? Because most of the funds coming from the taxpayers, which are the public, which are the people. This public also can use this misinformation to spread it, causing more harm than the pandemic itself. So the biomedical has become a source. I'm sorry, just a second, because something. So a biomedical literature is worthless to best, as dangerous at worst. So how to manage the infodemic? Through bioethics education, and not only education for researchers, but also to public, to observe this research, how they are conducted, and to report, and most importantly, to act and force sanctions on this research. We should communicate with the media. We should provide, as our job, provide clear, consistent information, use multiple channels that is used today, like social media, traditional media, to reach the public, to collaborate more with this platform and do our work. If we see something wrong, we have to report it, we have to flag it, and to ask to remove it from the media. UNESCO is combining its force with the other agency to spread the word about disinformation in COVID-19, and they published the different document about this infodemics, differing COVID-19 disinformation in brief 1 and brief 2. And together with the other agency, they are starting to strengthen the work to counter the COVID-19 infodemic. So as a conclusion, infodemics presents a unique ethical challenge during healthcare crisis where misinformation threats public health and trust in the system. We need to prevent and manage this infodemic across through collaboration across governments, media, and health professionals. And we have ethical responsibility to ensure truth, equity, and protection of the people interest. So at the end, I would like to leave you with this say: through combining strength, we are rolling out a concerted push together. This will help to monitor misinformation and empower people to recognize falsehoods, and at the same time increase people's access to accurate information. Thank you.